An effective health insurance system plays a significant role in managing healthcare resources, enhancing life quality for people, and maintaining social stability. However, the increasing number of collusive frauds has become a severe social problem, with groups of fraudsters buying drugs to resell them for cash. Detecting collusive fraud in health insurance faces two challenges. First, it is difficult to distinguish the medical visits and behavior of fraudsters from those of normal patients. Second, manual auditing is necessary but laborious. To address these challenges, we propose a novel three-stage visual analytics approach to detect collusive fraud in health insurance, which consider visit pattern of fraud groups and expert knowledge. We use two cases to demonstrate the effectiveness of our approach. Case 1, examining crafty fraud group. A health insurance auditor wanted to detect complex patterns of fraudulent behavior. He selected the drugstore and community hospital in the patient attributes view, as these institutions are poorly regulated and prone to fraud. He noticed a significant decrease in the number of patients with 1-20 visits. The majority visited drugstores and community hospitals between 21 and 60 times. Based on prior knowledge, this set the maximum time gap for co-visit to 1 hour and the number of co-visit to at least 2. To avoid missing collusive fraud, while excluding single patients and small groups of only 2 patients, he set the minimum group size as 3 and adjusted the minimum number of co-visits from 4 to 2 to generate the co-visit network. He then clicked on the button to generate the co-visit network and browsed the results of the collusive fraud detection models, which contain 48 groups. To filter the groups with short visit intervals, he selected the 0-1 minute bar in the chart about the minimum gap within the co-visit in the group attributes view. In the remaining groups, he noticed that the 2 groups in the patient co-visit network are very closely connected. 4 surrounding points connected to them aroused the expert's interest and were therefore added for analysis. In the patient comparison view, he noticed that the selected patients had low disease similarity and high drug similarity. To understand why diseases and drugs did not correspond, he selected all the patients and found that their fees fluctuated wildly. He then went to the patient behavior view to investigate the details of visits. He noticed a spike in the timeline of the number of visits and dense co-visit links in the visit sequence visualization around December 2019. Patients P0037 and P0960, in particular, had no medical records from January 2019 to November 2019 and rarely visited medical institutions after 2020. Their first medical visit was a co-visit in December 2019. So he narrowed down the selected time range. After adjusting the time granularity to week, he noticed multiple co-visits in the weeks of the 19th and 26th of December, indicating suspicious frequent co-visits in a short period. Such frequent co-visits in a short time were very suspicious. So he adjusted the co-visit time gap to 15 minutes and found that the co-visits of these patients all took place in institution 9,505,010, which was a drugstore he visited often. He hovered over the bar of co-visit to check the specific time of visits and found that their time of medicine purchase was very close, and many times within 1 minute. The cost of each visit was also within a certain range. He clicked on patients to view the specific information about diseases and fees. Results showed that all the diseases have no specific digestivity and are messy, and the cost of each visit was relatively fixed. Therefore, he speculated that these patients were likely a collusive fraud group and tagged with the corresponding labels. The subsequent investigation confirmed that these fraudsters colluded with salespeople to make money by frequently buying drugs for resale, while also helping drugstore increase sales for kickbacks. Case 2, excluding false positive group with chronic diseases. Another health insurance auditor wanted to exclude false positive groups, which were misclassified as collusive fraud because of collective visit behavior for chronic diseases. After reviewing the patient attributes view, she unchecked patients younger than 30 years old who are less prone to chronic disease. The bar chart on the number of visits and the number of people showed that the majority of patients with more than 60 visits were the patients retained after filtering and were also the primary visitors to various medical institutes. After understanding the basic characteristics, she proceeded to observe the co-visit network between these patients. The resulting network showed that almost everyone was connected. She attributed this mainly to the fact that the data contained numerous public hospital visits, making it easy for patients to have co-visits with others. She, therefore, excluded public hospitals and regenerated the network, where the number of edges was significantly reduced, and suspicious groups marked in purple were clearly visible. Some outliers appeared in the group projection. She hovered over one outlier and found that it ranked number 2 on the group list and its radar chart contained 4 anomalous metrics, For example, its number of co-visits reached 140. So she clicked on that radar chart and decided to further analyse the patients within that group. Using the disease bar chart, she found that the primary diseases in this group were chronic diseases such as back pain and hypertension. The top 5 drugs purchased included acupuncture, traditional Chinese fumigation medicine, and Kaianghu, consistent with chronic diseases. In the matrix view, after clustering the patients by disease, she found that P0056, P0252, and P0514 had a high disease and drug similarity, with P0514 and P0056 having up to 90% disease similarity and the rest having more than 70% disease similarity between them. She then selected these 3 patients, and the highlighted area in the bar chart showed their distribution in each attribute relative to the entire group. Most of these patients' visits were distributed in a community hospital numbered 9202. The area chart about fees reflected that their medical insurance expenses are relatively stable. She suspected the 3 patients might have been mistakenly detected as a collusive fraud group, so she moved to the patient behaviour view to investigate visits behaviour for further confirmation. She found that the pink bars representing back pain dominated the visit sequence visualization and appeared at regular intervals. Between September 2019 and March 2020, there were multiple co-visit links between P0252 and P0514, so she swiped the timeline to this period. She selected 1 minute in the drop-down menu of the co-visit time gap to analyse the detailed records of co-visits within this threshold. From the co-visit view, she learned that these patients visited the community hospital number 9202 every week or so. The height of the bar also showed that they spent about the same amount each time, consistent with the usual regular drug change cycle. Clicking on patients P0252 and P0514 revealed that their ages and total fees were similar, so she inferred that they might be patients who knew each other and went to the doctor together. So she marked the group as normal in the annotation view and gave the corresponding reason.